Again, thank you for having me today. Let's chat a little bit about how we manage incontinence after prostate treatment and how we're doing. Uh, these are my disclosures. And so we'll do a brief overview of incontinence after prostate treatment. We'll follow it with current evaluation and treatment. And then we'll touch upon some challenges in the management of IPT. Incontinence after prostate treatment, or IPT, it's the term that has been adopted by the guidelines. It's a little bit more of a more inclusive of a term. In general, the biggest component of IPT is going to be post-prostatectomy incontinence, but as we know, radiation therapy can also affect continence, and of course benign prostate surgery. It also, the term IPT can encompass not just stress incontinence, but all types of incontinence that may come about the treatment of prostate maladies. And it's, it makes sense because the management of a lot of these conditions is going to be pretty similar. So starting with a brief review, as most of you all know, prostate cancer is a very common cancer, about 300,000 new cases per year. But localized and even advanced cancer patients are going to have an excellent 5-year mortality, which is extremely low. And most of them are going to be around, and a lot of them are going to have some issues that derive from their treatment of their prostate cancer. So this is about 1% of the population of the United States right now. So making improvements in their quality of life can have a huge potential impact. IPT, just briefly from an anatomic standpoint, can come from injury or removal of the intrinsic sphincter. That it can occur during prostatectomy or during bladder outlet procedures. There's also the potential for nerve damage, either permanent or temporary, from energy, and so there are several mechanisms that can be involved in IPT, including the loss of sphincter function, nerve damage, as we discussed before, but also muscle and structural damages in changes in urethral support. There's also some thoughts that the increased prevalence of overactive bladder type symptoms may be due to some ischemia of the truther muscle, and basically a reconfiguration of the bladder neck after surgery. Risk factors for IPT include age. The older you are, the higher the risk of IPT. Pre-existing lower urinary tract symptoms. Obesity, I have it with a star because it appears that initial incontinence is worse on obese patients, but it seems that at the point of recovery of continence, obese patients have the same rate of return of continence as patients with a normal BMI. Of course, not being able to spare nerves is going to affect the external sphincter more significantly, and not surprisingly, extensive bladder neck dissection due to prostate configuration or prostate size is going to increase the risk of IPT. In terms of recovery of continence, this is particularly important for patients who undergo prostate surgery. Most tend to regain social continence within 6 to 12 months. And when we talk about social continence, these are patients that may use no pads or may use one pad for safety, and that's kind of what we mean by that. It may not be absolute continence under any condition, but under most most conditions, these patients are going to be dry. However, we do know that that persistent incontinence beyond the 12-month mark can affect up to 5-10% of patients, depending on how strict of a definition we have of incontinence. If what we mean is absolutely dry, it's going to be a bit lower than if we're talking about patients wearing 0 to 1 pads per day. In recovery of continence after a year is seen. However, the rates of improvement tend to be quite modest beyond that. IPT can be quite impactful from a mental health standpoint. One of the studies here it's done in multiple countries, and it was done in men and women. However, what they found in the study of men was that up to 40% of men who reported incontinence had also reported elevated anxiety, and many of them were being treated for anxiety. From more of a physical standpoint, this group at UT Southwestern showed that after continence is recovered in a lot of patients, they can experience a loss in BMI. The thought is that men with incontinence tend to become inactive and gain weight because they don't want to leak. So how do we assess for IPT? The first and most important thing is don't assume everything is going to be stress incontinence. After 30% of patients after prostate treatments have a level of overactive bladder. So it's very important to characterize their type of incontinence. Their severity, yes, pads per day is a useful measure, but it's also important to figure out what type of pads, how wet they really are. I have patients that may wear 2 pads, but when you inquire a little bit further, what they're wearing is two diapers, and they don't change them until they're soaking. However, we may also have patients that wear 6, 7, 8 pads, and what they're wearing is thin shields, and they change them frequently after just a few drops. The degree of bother is very important. Potentially, if they're coming in to see you for incontinence, you assume that they are bothered by it, but a lot of the times they may be sent to you by their family members or their doctor, and they may not be all that bothered by their level of incontinence. Questionnaires can be useful. The 2 most prominent ones is the ICIQ short form and then the Michigan ISI. Full disclosure, I don't routinely use these in my practice. I do like to get an IPSS mostly because I want to see the extent of their irritative symptoms. In terms of physical exam, you want to make sure that you confirm this stress urinary incontinence, and there are many ways to do this. Pad test it's a useful measure, and some people do in office 1-hour pad test to have the patient walk around, do some of the provocative maneuvers, bend over, cough, laugh, do that kind of thing, and then they weigh and assess the volume that came out. This can be logistically quite difficult to do. Some people prefer doing 24-hour pad tests, which can also be a little bit cumbersome. I find that in my practice, one of the most practical thing is to do a standing cough test. Standing cough test. Basically, what you do is you have the patient try to have the patient avoid voiding for previous 30 to 60 minutes. And then have them cough prompted about 4 times, and it's a fairly straightforward scale. Yeah, 0 is patients do not leak in all 4 coughing events. Then 1 is going to be some drops towards the end of the coughing series. 2 is going to be early drops, and then 3 is going to be a late stream, and 4 obviously is going to be an early stream, and those are worsening levels of incontinence. I think the biggest challenge with the standing cough test sometimes is that patients void before we see them, or somebody just grabs because they want to have a urinalysis. That tends to be a lot of knee-jerk reflexes in our clinics. I do like to get a PVR, so sometimes that can also get in the way of getting a standing cough test. However, I will tell you what I do to try to get a more accurate idea of their continence. So what I do is after I get a PVR, and if I'm doing a cystoscopy, which it's supported by the guidelines and an important part of the evaluation, I usually fill their bladder or have their bladder comfortably full, and then perform the standing cough test after cystoscopy. But cystoscopy is useful. It allows you to make sure that there's no pathology in the outlet. There's no bladder neck contracture in those radiated patients and those who've undergone bladder outlet procedures, or if there is a vesical urethral anastomosis, stenosis in those post-prostatectomy patients. It also allows you to do a repositioning test, which is essentially assessing the coaptation of this external sphincter before and after applying some perineal pressure. This can give you an idea of how well patients may respond to having a sling placed. I also, especially in those radiated patients, I like to look at their bladder, see what level of damage they may have. They may have pretty extensive radiation cystitis, and also just get an idea of what their capacity and their compliance may be, as this play an important role, especially in when it comes to urinary sphincters and slings. Urodynamics not usually needed on most patients that have been treated for prostate cancer or for bladder outlet obstruction. There are some scenarios where either by history or by examination you are not sure that they have stress incontinence, or that their urge incontinence component may be more significant. Also, again, if on examination I see a lot of radiation damage, or maybe what looks like a smallish bladder, I like to assess the compliance before we embark on invasive treatment. So how do we manage IPT in Italy? I think at the beginning, the most important thing is focusing on strengthening the pelvic floor muscle, and this can be accomplished either by PFME, which we call pelvic floor muscle exercises, versus pelvic floor muscle therapy. And the difference here, at least in nomenclature, is PFME is you teach the patient how to do exercises, or give them a handout or a video or something like that, and good luck. Hopefully this helps. Whereas pelvic floor muscle therapy is working with a professional, usually a pelvic floor physical therapist, and getting appropriate feedback on how to engage this muscle. PFMT seems to have some better results, at least short term. However, for most pelvic floor physical therapy, long-term outcomes are a little bit lacking. Uh, in terms of prehabilitation, the recommendations to try to for patients to try to learn their exercises 3 to 4 weeks before surgery, so that they can take advantage of those neuromuscular adaptations and know how to do those exercises before they have to deal with recovery and pain and so forth. But again, unfortunately, while pelvic floor therapy appears to help people regain continence earlier, it doesn't seem that after a year at the point that those who have received therapy versus those who haven't have any different outcome. Uh, in terms of pharmacotherapy for IPT, uh, OAB medication for urgent continence following AUA guideline for overactive bladder is what's indicated. There are some off-label treatments that people have tried, and most importantly, it would be duloxetine. This is an off-label, treatment. This is not approved in the United States. It's not approved in Europe. But people have used this serotonin and norepinephrine reuptake inhibitor that acts on a nucleus. You may remember that from your neurourology. It has somatic innervation of the urinary sphincter. Most trials have been done on mild to moderate incontinence, which have seen some improvement. However, due to side effects, discontinuation rate is quite high. So, if we move on to the surgical management of incontinence, we got to talk about timing. It's important to discuss with patients that early on they may have some bad incontinence, but over time this is going to get better on most cases. However, at the 12-week mark, it's reasonable to offer surgery to most patients that are significantly bothered by their incontinence. Those who are really bothered and have really bad severe incontinence at 6 months, you can discuss surgery with them. I don't think I would offer surgery earlier than 6 months. So what's available these days for surgical management of IPT? Well, we have slings, we have urinary sphincter, we have balloon devices, ProAct, which is something that became available a few years back and has been slowly gaining popularity.
And hey, Dr. Ortiz, I have a question.
Yes. Yes, go ahead.
Are you really ever doing like any of these procedures from in the 6 to 12 month like post RALP
yes
time point? Because I know like even if you're having bad incontinence at 6 months and you haven't improved at all, there's still a few percentage of people that will continue to improve from that 6 to 12 month range. So how do you see patients to get their treatment done from the 6 to 12 months?
Well, I mean, we talk about that. It's a lot of it is counseling the patient. I mean, I feel, those patients, those patients, they get up, they just leak all the time. They basically don't void. They just go onto their diapers, and they're miserable. I mean, the likelihood that patient is going to somehow become, very dry to the point that he's not going to need any kind of intervention, I think is very rare. Now you could argue that patient may become, maybe a sphincter at 6 months, and may become somebody that is going to need a sling or something else later on, and we always discuss that possibility. But a lot of these patients are just absolutely miserable, and if in my opinion they're gonna require some kind of intervention, I don't necessarily make them wait. It's not a lot of patients that are this way, but I do see a handful of this a year.
Thanks.
Okay, yeah. So let's talk about slings and the main available option for patients in the United States are going to be fixed slings, and the two most common ones are going to be the Advanced XP and the Virtue, the quadratic sling. There are some other adjustable slings elsewhere, but are not FDA approved. In this picture, we have the Advanced XP, which is a transobturator sling, and the idea is that perineal placement of this sling repositions the bulb of the urethra and causes a little bit of obstruction and movement of the urethra that allows to improve continence. The other sling is the quadratic sling, which has the transobturator component plus this extra set of arms that produce compression on the urethra itself. Their outcomes seem to be comparable. I use the Advanced. It's easy, straightforward, and the nice thing about slings is their passive mechanism. I think that's quite important. However, the level of continence that they're really going to be helpful for is mild to moderate. They're not all that helpful with severe incontinence. Unfortunately, because of the reaction that radiation causes around the prostate and adjacent tissues, the movement and the repositioning of the urethra is a little bit more challenging with slings. So they don't really work all that great on most of those patients. Surgically, the risk of this type of procedure, retention gets better on almost everybody within the first 30 days. Perineal pain and paresthesias may take a little bit longer to get better, but a lot of them, on most patients, they'll get better within a few months. Moving on, an artificial sphincter, only one approved in the United States right now. It's the AMS 800, the 3-piece device where there's a scrotal pump to operate the device. There's a cuff that compresses the urethra, and then there's a pressure regulating balloon, which is where the fluid travels when the device is open. I tell patients it's not so much like an off and on switch, but it's more like a timer switch where you push, when you push the button on the scrotal pump, it's going to empty the cuff, and then the fluid it's going to slowly make its way back from the pressure regulating balloon, and that's how it closes. It produces a more physiologic way of voiding because it's not closed off immediately, just kind of peters down over 30 to 60 seconds. Now, because it is an active mechanism, you do have to take into account patient's hand dexterity and patient's mental status. Obviously, the patients may not be, demented, or may not be immediately after or during the time that you place the device. So you also have to think about what may happen 5, 10 years if the patients continue to have have an artificial sphincter at that time. Um, AUSs are good for any and indicated for any level of incontinence, and it's basically the workhorse for patients who are radiated. However, they are far from perfect. They are a very delicate device, and revision is fairly common, to the rate of almost 6% per year. So at about 5 years, 30 to 40% of patients will need a revision, and at about 10 years, almost 50 to 60% of patients will need some kind of revision. That being said, in the absence of infection, we can go in and downsize or reposition or do whatever we need to do with the sphincters. Urethral atrophy, something that happens due to the constant pressure exerted from the cuff on that particular segment of urethra, and patients generally present, after a couple of years with worsening incontinence, and what you see is similar to what we have here at the top left corner. This is with a closed cuff. You can see a gap there where the urethra has become narrower, and now the compression from the cuff is not quite as adequate. Infection by itself is fairly rare. I don't know that I've seen it too many times, but generally when you see infection, you have to think about erosion. Erosion of the urethra by the cuff can present in many ways. You have to have a pretty high index of suspicion. Sometimes it can be subtle. It can be a small tear, like the one we see here at 3 o'clock on this patient, and that may just present as some incontinence or some occasional hematuria or some new pain, but sometimes can be quite severe and present like a rip-roaring infection with swelling and extravasation, and they can be quite extensive. It's an example of a full circumferential AUS erosion. The newer option is PROACT. It's this pair of adjustable balloons that are placed, as you can see, quite high above the urogenital diaphragm, ideally at the area of the vesicourethral anastomosis. This is accomplished with use of fluoroscopy and cystoscopy. It does appear to have a bit of a learning curve, and I think that has limited its adaptability. I last checked. I don't think that there's anybody offering in Louisiana at this time. Neither in Virginia, for that matter. I'm trying to get it to our hospital, but I'm still working on that. The nice thing about PROACT is that it has this ports that get located in the scrotum, and they can be accessed in the office, and adjust and fine tune the level of continence, over a period of time. So again, for the PROACT, nice thing, it's a passive mechanism. Again, you don't have to worry about, the patient being able to operate it, the patient, being aware that it's there. It's adjustable. It seems to work on all levels of continence. However, the outcomes on radiated patients, they're modest. So that's a bit of a bummer. And as you can see, bladder perforation during this procedure can be quite high, and explantation rate is quite high as well. I'd like to see, what outcomes become as people become more proficient at doing this procedure. Hopefully, something that will be a little bit more reliable over time. Bulk.
We have a question.
Go ahead.
Dr. Ortiz. So the explantation rate Do you have any information on why they're being explanted, like infection or just not being useful?
I think so. Several of these were they appeared like they migrate. So several of them were due to bladder or urethral perforation, but a couple of them were also due to malposition or migration later on. I don't remember the exact breakdown. The one nice thing about this is that you can explain them directly in the office. You can just deflate the balloon and pop it out. And I've talked to several people who do them, and they say that it's just not that difficult.
You can pull it out in the office?
Yep.
Out of what?
Yes, sir. Because it's funny, but they're just a little balloon, and once you pull out all the fluid, you can kind of pop them out. Again, I have never done it, but the people that I have talked to said.
You see something? I mean, you do a vasectomy.
Okay.
Just like small.
For the other percent of the devices that survive, however, how long does the device last on average for these patients?
Yeah, I think it's something newer.
Yeah, I don't know that we have really long-term survival of these devices yet. They're relatively new here in the US.
What's the data on the slings? I know you mentioned it, but is it a lot of them have problems with erosion or lack of
Erosion is fairly rare with slings. I don't recall ever removing one from now. I mean, I've only been in practice for 5 years, but even in fellowship, removing one for erosion yet, at least not in men. That's the nice thing about the bulb of the urethra. It's pretty sturdy, so quite different from sling in women. It's a lot of tissue there intervening. And most of the time, if they fail, we don't even need to remove them. And that's one thing that I do talk about patients when they're on the fence between getting a sling or getting an AUS, is that there's if they're not burning any bridges by choosing a sling, you can come back and put an artificial sphincter and not even ever seen, at least when I'm talking about specifically about maybe the advanced. You'll never see it when you place an AUS. And I think Lent did a study. I don't have it included in this presentation that showed no difference in outcomes on patients who had an AUS after a sling versus it being the primary treatment. For bulking agents, this there's no FDA approved. I'm just adding this for completeness. I don't do bulking agents. It would be nice if they worked. They just really don't, at least as far as I've seen. I have seen somebody who had 4 of these done, and they basically gave him its own vesicourethral anastomosis. So when we went and placed his AUS, he had retention for a little while. We even had to place an SP2, but eventually it resolved over time. So not a big fan of the bulking agent. This is just a brief summary here of in this review showed some of the success rates of the options that we just discussed. So as a brief summary, for mild incontinence, you can consider just about anything. Moderate, you probably don't want to use bulking agents in those patients. And for severe incontinence, we really are talking about artificial sphincter adjustable balloons. And this is, of course, on non-radiated patients. So let's just briefly touch on some challenges in the management of IPT. I think one of the important ones is satisfaction with treatment. There's a study out of Belgium. They looked at about 260 patients, and it very interestingly, they showed that the level of social continence went down over the years, and at 5 years, this was their median follow-up, was about 61 months. Their social continence was about 60%, which is less than stellar. However, when they looked at satisfaction rate, they found that as long as the patient had a functional AUS, and it was helping them stay dry no matter how dry or how well it was working, and even if they'd seen a decrease in its efficacy, they were satisfied. So that just speaks to the level of how much you can make an improvement in patients' lives with this type of treatment. This was a study from the UK where they actually did a randomized controlled trial between slings and AUSs, and if you look at their satisfaction, well, it wasn't astonishing. Male sling had maybe 55, and then AUS about 65%. They did most of them by and large would recommend their surgery to a friend. 80% of sling recipients would recommend their surgery to a friend, and 95% of patients who underwent the AUS. But what happens with the patients who choose not to have any kind of treatment? The group at UCSF looked at decision regret about management stress incontinence, and they came up with this funky graph. But basically, the orange line shows you what anything above that is well, they call a high decision regret score. And essentially, as you can see, most of the high decision regret score happens in patients who opt not to have surgery. And when you break it down by sling and sphincter, sling seems to be, most people seem to be very satisfied. There's a small sliver of AUS patients who may not be happy, but I suspect that a lot of them is patients who've had either complications or require multiple revisions, and probably have worse baseline incontinence. Although that's just my conjectures. Another question is what works best for moderate? Let's say you have a patient that says, listen, the most important thing to me is to stay as dry as possible. I got good hands, I got a good mind. I don't love the idea of having to push a button every time I urinate, but to me the most important thing is to have continence, to be as dry as possible. So what's better, doc? Is it an artificial sphincter, or is it a sling? So if you let patients choose between those two things, most of the time they're going to choose an AUS. Most of the time they're going to choose the sling. I'm sorry. The Dr. Nidhi at NYU did the study where they looked at patient preference. So if the surgeon recommended an AUS, about 75% of patients went with that. If the doctor recommended a sling, 100% of people went with that. But if the doctor said, "Hey, you choose, either one is fine," 92% of patients are going to want to have a sling versus an AUS, and it makes sense. I think if most of us would probably want to have something that you don't have to manipulate, and that makes you feel like you're closer to where you were before you had your treatment. When I was in fellowship, we also had this question, so we looked at our series, and we found that That's length. We compared length for mild incontinence to length with moderate incontinence, and then we looked at length for moderate incontinence versus AUS for moderate incontinence. And what we found is that length worked better for, had a higher success rate in mild incontinence. And then when we looked at moderate incontinence, we saw that there's significantly higher on patients who had an AUS versus a sling. This group in Italy had similar findings. They looked at their patient population and looked at sling versus AUS, and they found that basically at all follow-up points, 6, 12 months and last follow-up, continence rates with artificial sphincter were superior in patients with moderate incontinence at baseline. This is also pulled from that randomized control trial from the UK. The forest plot shows higher satisfaction on patients who underwent AUS. Another one to touch upon is how we fine tune treatment. The only thing that we can really do these days post-operative is on PROACT. You can actually adjust the continence, but fixed lengths, they kind of stay the way we place them, or they get worse over time. You can't really make them better. With artificial sphincters, our only option when it's really downsizing the cuffs when they undergo atrophy. So some people have tried to come up with options. None of these are available right now in the United States, but they're all adjustable slings. This is the Argus T, which is a transobturator device, which uses this washers that can, be adjusted intraoperatively with, for revision surgery. The Remex is a device that is placed perineally, but also infrapubically, and has this tensor mechanism that is left in the suprapubic area, and can be later accessed again through surgery to adjust the tension on the sling. The last thing, and here on the right corner is Adams, which is basically a transobturator sling with an inflatable pad that compresses the urethra. The nice thing about it is that it has that type of scrotal port that can be accessed and in the office, and the level of fullness of this pad can be adjusted. So lots of modifications here. Unfortunately, nothing has caught traction, mostly because the outcomes are not all that much better than what we have with fixed slings these days. Last thing I wanted to touch upon, obviously, in challenges on IPT, is management of radiated patients. Radiation, we know, is an independent risk factor for AUS erosion. Most patients are going to be treated with AUS. When they have atrophy, and you have to downsize the cuffs, there's also a little bit of a lower limit. We have found that the 3.5 centimeter cuff, which is the smallest available cuff for AUS, has had up to 25% erosion rate on radiated patients, which is at least twice as much as the average erosion rate, which is somewhere between 8 and 12% on with other cuffs and even in radiated patients. Also, management of mild incontinence in these patients remains a challenge. it's, some people advocate for use of slings in radiated patients with mild incontinence. There's some people look at their reposition test and to make that decision. As we know, radiation can have very variable effects on the anatomy. So if sometimes the surgeons may feel that the patient has a good reposition test, may consider a sling in this type of patient. Obviously, the presence of lack of hand dexterity or any kind of mental impairment remains a challenge, especially when we follow these patients longitudinally. I have had some of my patients that they were not really some of my patients. They were patients that came to me maybe 8-10 years after they've had their AUS placed, and who have unfortunately worsening dementia, and we've had to deactivate their devices. Now, we've done that, and they've done well, but it's something that is simple to consider.
How did you do that?
But, I'm sorry?
How did you deactivate their device for these?
So
DVR high risk for the OR that you want to deactivate?
So you can deactivate and activate the artificial sphincters in the office.
Right. I'm saying I had a patient, just for reference, that kept reactivating. He was demented and kept reactivating his device and everything like that.
I have seen some reports of people actually puncturing the devices. And I haven't done it myself, but I think that would be an option, especially if the patient is a high risk for the operating room.
Awesome. Thank you.
Yeah, or just
We've already had.
That's what we were
transstrudal.
We did a.
Take a needle.
I had another question, for your patients that come to you that are neurogenic, have low compliance, talking like 200 cc's, and they have pretty significant, stress incontinence. You see stress incontinence on exam. They have already gone through the gambit. They went through suprapubic tube placement. They're still leaking. And is there a point where you're saying ileal conduit's the answer, and because this guy just wants to be dry?
Yeah, I mean, I think ileal conduit can be a reasonable option for those patients, and especially if they're healthy enough to undergo that type of procedure. I feel like that tends to be underutilized in some of those some neurogenic patients, unfortunately. You've probably seen that they have the suprapubic tube, they still leak from below, and their bladder is terrible. I think ileal conduit is underutilized in that type of patient. Unfortunately, a lot of the time, some of our patients here, the IPT patients are going to be a lot older, a lot more frail, a lot of times, and those can be quite a challenge. I think that's another challenge. I don't want to go on forever about what's challenging about IPT, but yeah, how we manage those patients that have undergone maybe a couple of erosions, or and are not really great candidates to sustain an ileal conduit. We did some posterior urethral ligations with Almori when I was in fellowship, but those patients had a lot of trouble. They had perineal abscesses. They leaked through our closure. And I think part of it was in those who had prostate or had a posterior urethra with an open bladder neck. Probably there was a lot of irritation from urine, getting to that area. Bladder closure and urethral closure for those patients can be quite challenging. I think the robotics has improved that some, but it's still a challenge.
Dr. Ortiz, one other question. For your patients that you're gonna put a cuff in that have had a vesicourethral anastomotic stricture, how many months do you wait? And does the type of treatment they had for the stricture influence your decision?
So I generally, I'm fairly aggressive. If I do their VUAS treatment, and they're open at 6 weeks, I book them. So I don't necessarily wait months. And the way I normally do them is I balloon dilate the VUAS, and then I do a pretty aggressive 3 and 9 cuts with a Collins knife to fat. And if 6 weeks later they're still open, I proceed to the operating room.
What about
And
the radiated ones?
I'm sorry.
What about the patients come to you with the history of radiation and bladder neck contracture. Would you do AUS if they have incontinence, or how long would you wait after opening the bladder neck after radiation? The same thing?
Same thing. Same thing.
So if it recurs, then it's a little more challenging to go back and do the.
It can be, but it's at least what I've seen so far, it's fairly rare if you're aggressive enough.
By aggressive, you mean that you just cut the bladder neck, or you just resect the bladder neck?
Cut the bladder neck at 3 and 9 all the way till I see fat.
Okay, thank you.
After balloon dilation.
3 and 9.
Have you used Optimal?
Correct. I balloon dilate because it's hard to get it's hard to get that the Collins knife in a good position and so forth. But after balloon dilation, we'll go 3 and 9. I have also tried on some people who are not necessarily incontinent, but we've done more on bladder neck. We've done Optilume and I would say so far maybe a 50-60% improvement rate on those patients, which for recalcitrant strictures is really not bad.
I have a separate question. Sorry. So for patients who are candidates for AUS, have you noticed any difference between their surgery or outcomes depending on what type of prostatectomy they had, whether it's posterior or rectus-bearing or intravesical or anything like that?
That's an excellent question, and I don't know that I haven't really looked at that. But that's very interesting to think about.
And will you do?
I'm saying, like, once they're
Will you do like a 30 Optilume balloon originally, like to start with at the bladder neck now, and then make your cuts?
No. So I usually I will pre-dilate with a Uromax, and then do our cuts, and then if but this is so the ones that I've treated with this are kind of two separate things. The ones I treat with the cuts, I don't usually Optilume. I have Optilume, some that have failed, and I've had pre-dilated them with the Uromax just because I think you can get a little bit more pressure on the Uromax. The 30 French balloon for Optilume, I think it's only rated for about 10 atmospheres, and you can get a bit more with the Uromax one. So I initially, and this is outside of the topic, but I used to not do any kind of mechanical manipulation to the stenosis, and then I started, and I think meaning either a Uromax or a DVIU or something like that, and then put in the Optilume, and I think while it increases the cost, I think the outcomes are a little bit better that way.
Cool, very good.
Thank you.
All right.
Thank you.
All right. Well, thank you very much. It's good to see, LJ, Dr. Caso, Alexis, everybody. And thank you for having me tonight.
Thank you, Dr.
Thank you.
Ortiz.